Well, hello everyone. I'd like to welcome you to the program Billing and Coding for COVID-19, reporting the coronavirus related services, including some telemedicine. And before we even get started here, this is so fresh. I mean, literally some of the numbers that you're going to see have literally just come to our attention since a vote on Congress's floor at 1 o'clock this morning. So with that said, we with Arch Pro Coding are certainly not afraid to say we don't know if we don't know. And frankly, right now, this is so new and fresh that I think that there's been some misinformation out there. And I want to be very careful to make sure that I am not disseminating any information that is inaccurate or incorrect. So full disclosure, let's work through this together. I'm glad that everyone is able to join us here today during this time of anxiety and uncertainty. A big step there was a big step that actually took place this morning with a vote that basically a stimulus package that's going to mean a great deal for a great number of people throughout the United States. And let's just go ahead and get started. Again, my name is John Burns. I serve as the Vice President of Audit and Compliance with Arch Pro Coding. Been in the business for about 25 years now, and spend a lot of my life, doing audits and providing training and education relative to the findings from those audits and investigatory work that we do. If anyone needs me or wants to reach out to me, I know that my email address, I've provided it on the final or the last slide of this program, but I'll go ahead and give it to you right now if you wanted to jot that down. It is jburns@archprocoding.com. Again, that's JBURNS at ARCHPROCODING.com. Let's go ahead and dive right in. So what are the goals that we have for this presentation? Well, I think we have to discuss what the coronavirus is. And we've been hearing about this for weeks on end at this point. I think most of us are certainly familiar with what COVID-19 is. It's one name that has been provided to this disease that has reached pandemic and epidemic proportions here in the United States and around the world. We really want to focus on, those aspects of this particular thing that play into documentation, coding, and billing perspectives. In particular for RHCs, FQHCs, and we've got some information scattered throughout the program as it relates to critical access hospitals as well. I don't want to say that this program is all encompassing. I'd like to provide everyone online here with some tools and some resources, and certainly some links that you can find throughout the program and the presentation that I put together in order to continue to research the matter further on your own. We have to talk about what the CPT, HCPCS Level 2, and ICD-10 reporting parameters are. And again, we can't go through all of them, but I can give you an idea, as to the two HCPCS Level 2 codes that were created for CDC versus non-CDC lab testing for the coronavirus. And also, I really tip my hat to the American Medical Association with the speed that they actually used in creating a CPT code specific to reporting the COVID-19 coronavirus as well. So we'll talk about those coding parameters, of course, throughout the course of the program. We have to get into, how has this really impacted our lives? Well, in every way, shape, and form, in my opinion. I mean, I've got my daughter here at home, homeschooling. It's the first time I haven't been on an airplane in a month, probably in my professional life. A lot of our lives, as we've always known them, have changed. And with this, I think that there's some great opportunity with regards to telemedicine, specifically telehealth visits, virtual check-in services, and e-visits. Now, we have to understand that Medicare has their rules, and I will use that as my foundation throughout the course of our discussion here today. But just because Medicare's rules apply for Medicare purposes, we cannot assume that the same is going to trickle over and apply from a Medicaid perspective, and certainly, throughout the commercial insurance industry. So I'm going to use CMS as our foundation, but it is important that you understand the state that you are in and what the Department of Medicaid within that state requires you to do for reporting similar services. Case in point, a question that I've seen, and I know that I'm included in a number of different listservs, and one of the questions that I've seen continually over the past week or two is, how is it that we are to report these virtual communication services, specifically virtual check-ins? Okay, and I know that there are codes out there, HCPCS level 2 codes. If you wanted to jot them down, they're G2010 and G2012. But these are for check-in services essentially, but they are not specific to RHCs and FQHCs. So I've seen folks offer people perspectives or opinions saying that they should be reporting those two codes. And my question would be, first, do you represent an RHC or an FQHC? If the answer to that question is yes, neither of those codes is the code that you should report at this point in time. Rather, there is a G0071, which has been created for a visit that typically takes 5 to 10 minutes, and it pays just about $14 a pop. But that code, G0071, is the code that should be reported in those cases, okay? So again, it's just important for us to understand our payer mix and the landscape, and know that just because Medicare has a set of rules, as it relates to coding and billing, it doesn't mean that it's going to apply to the commercial insurance industry, or that it's going to exactly coincide with whatever the Medicaid reporting requirements in that particular state are. So there is a slide that you'll see a little bit later on that goes into a little detail with regard to a couple of states where the Medicaid programs have actually released information in the past week to 10 days to basically explain how telehealth and virtual check-in services are to be reported specifically for them. We have to talk about the Corona Aid, Relief, and Economic Security Act, called the CARES Act. Again, with this and with the vote on the floor of Congress this morning, there's a massive stimulus package that's recently been enacted to the tune of some $2 trillion. I think that represents the largest stimulus package in the United States history. So it's something that's so fresh and so new that during this time of isolation, I'll have a little bit of time to read through all of those pages in the days and weeks to come. There is a waiver that we have to discuss, and it pertains specifically to telehealth, which allows, with this 1135 waiver, would actually allow for patients to receive telehealth services regardless of their location. So historically, when we talk about telehealth services, especially from FQHC, RHC perspectives, we're talking about patients who are actually located in census-approved, rural or in some cases urban, but typically rural areas that are underserved. And with that waiver, it basically allows any Medicare beneficiary in the United States during this pandemic, even if it's their home, that would qualify under this exemption as being applicable for billing telehealth services. So that's kind of a big change that came out. Section 4405 specifically is what speaks to that particular item. And again, I'm going to provide you some valuable links and tools throughout the course of the program that hopefully you can use in order to continue to educate yourself, and more importantly, just know where to go and look for information when you find yourself needing it. Because again, I'll do my very best to give you everything that I can in a truthful, honest, and authoritative, using authoritative sources to back up the content of this program. But again, it's important that we all know where to go and find information in the event that we need it. So there are some links that I'll provide you to hopefully do just that. So what is the COVID-19? Well, it's a virus that was originally named the SARS. The CO is the corona, but that's basically the CoV2. That was the original name that was provided to this disease, but it was more easily named and coined the coronavirus disease of 2019, which was abbreviated to COVID-19, which is what we'll call the coronavirus. It's a novel virus, or the novel coronavirus is how we heard it referred to, early on throughout the course of this disease before it reached pandemic proportion, but it is characterized by a respiratory illness, and it originated in China. And we'll leave it at that for the moment. Now, according to the CDC, what a coronavirus is a family of viruses that is common in people and many different species of animals, whether it be camels, cattle, cats, or bats. And since January, this virus has spread to more than 190 countries and territories around the entire world. This is a global pandemic. It's not just the United States, as we all know, that's going through this. It's the rest of the world as well. And when we look at some of the things that are going on in other countries, whether it be Italy or Spain, it's scary, to say the least, how easily and how quickly this has spread. So I don't even know what words to use. The new normal is not something that I am quite accustomed to yet, but we're all in the same boat together. The World Health Organization actually characterized this as being a pandemic, and I believe that was back in February, but again, this is something that has reached global proportion. And as you can see, just specifically in the United States, this map hasn't been updated since March 21. If you were to look at this map now, updated today, being the 25th of March, you'd probably see states like Louisiana and certainly Florida, where you would see darker colors representing a higher incidence of infection within those particular states and territories. So some figures in the United States, and these are, they're staggering, and these numbers literally are changing every 10 minutes. So I've probably updated these slides because I started creating this program just about a week ago. And every day when I've actually looked at new data, I've had to change some of these. But as of about 10:30 a.m. Eastern time here this morning on March 25th of 2020, there were a total, just in the United States, of more than 53,000 cases, but almost 500,000 of them around the world. Were more than 700 deaths due to this national pandemic. And as you can see, nearly 20,000 deaths across the world. And the numbers continue to rise, and they will continue to rise based on every epidemiological reference that I've put my eyes on. There are many places, the United States being one of them, that is not, we're not even close to out of the woods. In fact, the apex is something that, we all hear about this, shortening the curve, kind of breaking the curve. Or as Governor Cuomo here in New York State might say, is kind of, he more talks about that curve as being a wave. And the worst days are definitely ahead of us. And hopefully our federal government and our state governments can work together in order to make sure that we're as best equipped for what's coming as humanly possible. Like I mentioned earlier, 196 countries have been impacted by this virus. Every state in the United States, all of the United States have been impacted by this virus. And it was declared a national emergency by President Trump back on March 13th. There was a link there where you could take it to the press release if you were looking for something to read. But most places and most hospitals, not just rural hospitals and critical access hospitals, but major hospitals across the country, many have canceled all elective procedures. We keep hearing this term of social distancing and avoiding contact with those that are at high risk. We know that it's the elderly and those with underlying comorbidities and diseases that are at the highest risk of contracting and being a part of that mortality rate as it relates to COVID-19. But with that said, it's important to understand that the young and the younger population, I think early on, were led to believe in many cases that they were, let's just say, immune, for lack of better words, to this disease. Well, that's not entirely true. And even for those that don't demonstrate symptomology, it's very possible they're walking around as carriers and giving this particular virus to those folks who are compromised and the elderly, of course. So the social distancing, is something that I've been practicing, and I know that most of you out there, or many of you out there, probably have as well. And for up-to-date information, if you wanted to see it's really a neat, very interactive type of site, but the hyperlink that you see on the bottom of this particular slide takes you to a real live interactive website that basically shows how the numbers in terms of confirmed cases, new cases, death rates, it's broken down by country, and you can either further break it down by state. It's a neat site if you were interested in looking at it. So let's talk about coding and the pricing for COVID-19. I mentioned a little while ago that starting in April, laboratories performing the test can bill Medicare directly with the use of one of two HCPCS Level 2 codes that were created and became effective earlier this year. The U0001. Now this is a CDC specific test. Any laboratories performing non-CDC laboratory tests would not report U0001. Rather, they would refer to U0002. And one step further, I had mentioned earlier that the American Medical Association took the initiative to fast track a new CPT code used specifically for testing for the coronavirus. And that new code that was recently released is 87635. And you can see the definition there. I don't think that there's really a need for me to read it to you, but that is the official definition that's been provided to us by the American Medical Association. And this is the probe technique. This is a infectious disease test specifically for coronavirus. Now, just a couple little tidbits for you. Independent RHCs out there, you'd report this service using the CMS 1500 form, or the HCFA if you choose to call it that. Well, provider-based clinics, of course, would report using the 0300 or the lab revenue code, and that would be captured on the UB. And if you wanted a little information with regards to how this service is being priced out, you can use the hyperlink that I've provided at the bottom of the slide for that purpose. What about ICD? Well, again, we can't go through every single scenario or possibility here, but we can certainly go through a few. So how would we report pneumonia that's due to COVID-19? Well, first we would assign that code for other viral pneumonia, and then B97.29, which is for other coronavirus as cause of disease. Similarly, for acute bronchitis due to COVID-19, we would first assign J22, followed by that code for other coronavirus as the cause of disease. And again, that code is B97.29. For acute respiratory distress syndrome, we would report first J80 for the acute respiratory distress syndrome, followed by again B97.29 for other coronavirus as the cause of disease. So there are a couple of examples as to how this would be reported. But what about patients who feel they've been exposed, as opposed to patients who have a confirmed exposure to someone positive with COVID-19? So the scenario here differs a little bit. For possible exposure to the virus, but it being ruled out, the appropriate ICD-10 code to report would be Z03.818. As opposed to actual exposure to the virus, that would be reported with Z20.828, contact with and suspected exposure to other viral communicable disease. Now, I won't read this to you, but the key takeaway here is, and it relates to telemedicine specifically, FQHCs and RHCs, when reporting telehealth services in the past, have always been limited to the originating site. And one of the big things that we've all, the bouncing ball that we've all been, kind of watching to see where it stands, it is now effective yesterday. It is now permitted for FQHCs and RHCs to actually qualify as also distant site providers during this emergency period. And that's big news. Well, that's big news. So FQHCs and RHCs now can actually qualify as originating site or distant site as it relates to telehealth. Some more recent actions that have taken place. There's been a toll-free hotline established for providers to receive Medicare billing privileges and an expedited application process. We've all heard the stories about how there may be, shortages of healthcare providers if there's not the appropriate equipment for them. The rate at which our healthcare providers and those folks on the front line could put themselves in harm's way and become infected themselves is on the rise. So there are attempts to expedite applications. As you can see by the second bullet here, an amendment to alleviate holdups in the visa process, allowing some 20,000 international nurses to start, assisting with the healthcare delivery here, making incredible efforts with regards to personal protective equipment. And this is something that we've all probably heard about a whole lot. I know that, here in New York State, our governor, Andrew Cuomo, every day has been providing press releases and really, really pushing for these ventilators to be released and allowed for New York hospitals to use, knowing, just knowing that the spike, and ultimately, just the pressure on the hospitals in New York State. And what's happening here, unfortunately, is probably going to be the case in many other hospitals in different states across the country moving forward. So there's a lot of effort that are being made right now in order to address these shortages of personal protective equipment. Working on payment solutions as it relates to, well, would we get the PPS or the all-inclusive rate versus a composite rate for telemedicine or telehealth services? More on that just a little bit later on. And CMS may. Now, I personally have not seen anything yet, but in the reading and the research that I've done over the past couple of weeks, it's come to my attention that there may be a modifier or a series of modifiers created in order to identify specifically that services have been performed during the COVID-19 crisis. So we'll just basically keep an eye out for that. But you see in parentheses here where it says cost sharing waiver. It is, I would not be surprised at all if we were to see a modifier that basically would lead to, much like in the rural health clinics, we think about the CG modifier. Well, let's think about something along those same lines. A modifier to say the service was related to COVID-19, at which point in time the patient's cost sharing, whether it be deductible or coinsurance. And I know in the FQHCs, the deductible is kind of a moot point, but again, in terms of coinsurance, totally different story. There may be a modifier that could actually identify this being a COVID-19 related issue or matter, at which point in time the patient's cost sharing would be eliminated. But again, I'm continuing to keep my eyes on that, and I have not seen anything to speak to any new modifiers, at least to this point. This is just a little snippet from CMS that came back out on St. Patrick's Day with regards to and what led to on March 6th, I think it was $8.3 billion of money that was actually introduced in order to really assist through this COVID-19 crisis, specifically to telehealth. A lot of that money was being utilized in order to help compensate for telemedicine and telehealth services that will be required during this time. So let's talk about telemedicine. Now, telemedicine and telehealth, I think a lot of people use these terms interchangeably. I'm not going to say anything is right or wrong, but typically telemedicine services are, I think about them really in being in terms of three different, let's say, ranges. Okay, so telehealth codes, virtual check-in, and e-visit. So we'll start with telehealth visits. And again, I cannot emphasize this enough. When you look at things like these G codes that you see here, we know that G codes, we know that these are CMS created codes. So there is no promise that any commercial insurance or Medicaid for that matter is going to recognize those same codes, okay? So telehealth visits are basically visits that would be allowed and paid generally at the same rate as if they were performed in the clinic or the health center setting. And the codes that would be used in these cases would be 99201 to 99215. And I wouldn't tell folks in RHCs and FQHCs billing the Medicare program to consider this until just recently, of course, because we were all limited to being this originating site and falling back on Q3014, which was the code for the originating site fee, which pays roughly $25, is at least $25 or $26. But the point is, telehealth visits are typically reported using some of the codes that you see here. Now look at the fourth bullet with regards to Appendix P, as in Paul, of CPT. That's where you can find a complete list of all synchronous or real-time, another word for that, telemedicine services, those things that are approved for telemedicine. But again, it's important that we know Medicare approved services may not be the same as other, certainly commercial insurance approved services. And the modifier 95, it is a modifier to identify a telehealth approved service. And in CPT, there's actually a symbol, it's a star that you'll see outside of a code that does represent a service that is approved in terms of, it's a telehealth approved service. You can find that in Appendix B of CPT. So those are telehealth visits. Now, when telehealth visits are being performed, this is a really important distinction as it relates to the place of service code. Now, a lot of folks have asked me, do we use place of service 72 or should we use the place of service 50 or 12 or 21 or 22? And the appropriate code for reporting telehealth services is 02. It is specifically a place of service code to delineate, to demonstrate that a telehealth service was indeed a telehealth service. Virtual check-in services. Now, there is a whole lot of misinformation that I've seen floating around out there as it relates to virtual communication services and virtual check-in, okay? Now, for anyone outside, all right, let's just talk about Medicare first, all right? So I'm gonna look at the fourth bullet here first, where it reads, for Medicare, RHCs and FQHCs must refer to G0071. That's true. Now, are there codes using either telephone or real-time video, video and images? Yes, there are. There are two HCPCS codes, G2012 and G2010. They are used for that purpose. That's what they were created for, but they are to be reported everywhere but RHCs and FQHCs. That code was specifically created for those entities, okay? So make sure that if you're in those locations and you're billing the Medicare program, don't use G2012 or G2010. Rather, refer to G0071, which typically is a virtual communication or a virtual, call it check-in service. It's at least 5 minutes, but typically 5 to 10 minutes, and it pays roughly $14. And then, of course, there are e-visits. And this requires a patient portal. That's really the big, that's the distinction between these visits and other types of telemedicine services. These require a patient portal in order for, to properly report them. So telehealth. If you looked at Chapter 9 of the policy manual, it says FQHCs and RHCs may bill as the originating site only. Well, there is now an exception that's been put in place as a result of most recent legislation, which will allow FQHCs and RHCs to also qualify as the distant site. That's huge. And whether that actually will extend beyond this pandemic or not remains to be seen. I know that there's a lot of folks that will probably be pushing for that. But Chapter 9 of the manual may need to be revised, down the line. But just know that Chapter 9 says that FQHCs and RHCs can qualify as the originating site only, and the reason for that is because that was the case until just very recently. All right. Now, effective back on March the 6th, the Coronavirus Preparedness and Response Supplemental Appropriations Act, HHS was given authority to waive certain telehealth requirements, and this is what leads us to something referred to as the 1135 waiver. Okay. With the 1135 waiver, it actually allows that originating site. We can look at that as actually qualifying as being the patient's home. And again, that's a pretty drastic change in the definition of originating site prior to that 1135 waiver. So again, something to be certainly be aware of. Along with that waiver, it actually allows for telephones that have audio and visual capabilities to actually be used for telehealth. In the past, we've always, heard based on HIPAA legislation, or the Health Insurance Portability and Accountability Act that we're all very aware of, I would imagine, from privacy and security perspectives. When you look at the fact that FaceTime and Skype can actually be utilized during this period to qualify, and the Office of Civil Rights has actually relaxed HIPAA requirements for providers that show good faith during this pandemic in trying to treat their patients using these other aspects or pieces of technology. So if providers can show good faith, even if there were to be a HIPAA quote unquote violation, providers would actually have a leg to stand on, if you will, in protecting themselves, saying this was during the COVID-19 pandemic. All right. So all of this is going to remain in effect until the public health emergency is over. And again, that's definitely down the road, and I can't even begin to prognosticate as to when. I cannot predict as to when that may very well be. So the telehealth codes, again, just a couple of little, for the originating site, all right, telehealth in FQHCs and RHCs is reported using Q3014. And the originating site as the originating site. And the place of service for telehealth services is always 02. All right. Now, the link that you see here will provide you a link to all telehealth services. Okay. So it's from CMS, but all covered telehealth services are provided for you using that hyperlink there. People have asked about modifiers. We talked earlier about the fact there may be new modifiers created. We'll keep our eyes on that as we proceed. But the only three modifiers, or the only three situations in which modifiers are required right now for telemedicine would pertain to one of these three bullets you see in the middle of this slide. GO, which is only for the use of in use or used for patients that have an acute stroke. GT modifier would only be required for critical access hospitals using method 2 billing methodologies. It sounds a little redundant, but anyway, I think you get it. And then GQ, which is reportable in Alaska and Hawaii as part of a federal telemedicine demonstration project. But outside of that, there are no modifiers that exist at this particular moment. That may change. All right. A temporary fix for RHC distant telehealth, it's included in section 45 or 4405 of phase 3 of the coronavirus aid recovery. I forget what the E stands for. I haven't memorized it yet. Shame on me. But the CARES Act, we'll just call it that to stay on track here. All right. And telehealth services require an E&M level with place of service 02, like we talked about earlier on the professional claim. And a GT modifier would be utilized if applicable on a facility claim, like we mentioned above, as it relates to method 2 in the critical access hospitals. So this is something I pulled from the CMS website yesterday, and initially my gut reaction and the way I was tempted to answer a question posed to me by a client yesterday, I was surprised to find what it is that I did. Okay, but it said, can a distant site practitioner furnish Medicare telehealth services from their home? And initially I'm thinking to myself, no. My gut reaction was no. But there's actually a caveat here. The answer is, well, yes, maybe. Okay, there are no payment restrictions according to CMS on distant site practitioners furnishing Medicare telehealth services from their home, but that distant site. My internet here at my home just went out for no apparent reason. I'm looking at the sunshine and I have no idea what just happened. So our connection has been reestablished. Hopefully that does not happen again. Let's jump in and get started here. Again, what I was saying earlier is that at this time, there's not been any issued approval to release an all-inclusive rate or an encounter rate for an RHC performing services via telehealth, okay? But there are some states that have actually weighed in on this, okay? So you can bill and receive your encounter rate for telehealth distant site visits or services in certain states like Illinois, and there are other states, and again, I urge you to check with your states, but Missouri, Alabama, Mississippi, Tennessee, Kentucky, these carriers have all also placed relaxed restrictions on telehealth and allowing for providers to serve as distant site even prior to the vote this morning. In Missouri, telehealth services may be provided to a patient while at home using only a telephone, and they'll be reimbursed to the healthcare provider delivering that medical service at the distant site equal to the fee schedule amount. Okay, so again, it's important that we understand that what CMS puts out there and what Medicare requires in a particular state, it may not perfectly coincide with the commercial insurance industry in that state or potentially commercial payers, of course, Medicaid or commercial carriers within that particular state. So virtual communication services, we talked about this a little bit, a little earlier. Starting back in 2019, these virtual communication services became payable for FQHCs and RHCs, okay? But the code that has to be used in these cases is G0071, like I alluded to earlier, all right? Now, a couple of caveats to this particular code and its use is that the medical discussion or remote evaluation, okay, it has to be related, or let me back that up. It cannot be related to any service that was provided within the previous week or 7 days. And it also cannot lead to an appointment, either the soonest appointment on your schedule or within the next 24 hours. If either of those things is not true, the code is not reportable. It would be inclusive to the all-inclusive rate that you'd be paid for that previous visit or the upcoming one. I hope that made sense. So again, the second to last bullet on this particular slide, I think sums it up and says that payment, it's set at the national, the non-facility fee-for-service national average, and you'd be reported using HCPCS code G2012. Well, again, G2012 and G2010 are not intended for use for RHCs or FQHCs billing Medicare. And that's the important thing I want to make sure I get across. And again, it pays roughly $14. E-visits. Now, again, this is more of a Part B service that would be reported as a Part B service to Part B Medicare when applicable, all right? But it requires the use of a patient portal. And you can see, and I put these things in bold just so that we could make sure that, we understand how important documenting time in these cases are, because the 99421 is for a digital evaluation and management service. Now notice it's evaluation and management service. Think of who can perform evaluation and management services. Not psychologists, not social workers, not physical or occupational therapists. And the reason that I point that out is because there's another series of codes that you can consider and take a peek at. I do not think that they would qualify for your all-inclusive rate or PPS in the RHCs or FQHCs respectively. But again, I wouldn't be surprised if it's possible that I'm not accurate in making that statement. But you can see how important time is as it coincides to each of these three codes for e-visits or digital evaluation and management services. Well, what about patients, or like we said, what about those clinicians who can't report evaluation and management services? There are actually G codes that have been created at the federal level, G2061, 62, and 63, which are used for qualified non-physician healthcare practitioners performing online assessments, not evaluation and management services, but assessments. And you can see that the times there are the same as they were on the previous slide. It really all boils down to who is it that's performing that online E&M service or online assessment. So just be aware that these codes exist for the non-physician or those clinicians that can't report evaluation and management services. A little information as it relates to our critical access hospitals. During this pandemic, there's been a waiver of the requirement that critical access hospitals limit the number of beds to 25, and the length of stay may be limited to 96 hours. There's a blanket waiver that's that will impact all of these hospitals. And if a Medicare patient needs to be admitted to a skilled nursing unit or a swing bed, the 72-hour restriction's been lifted. So again, it's pretty helpful. And swing beds, both in critical access hospitals and small rural hospitals, they're included in this exemption as well. There's another piece of legislation that's floating around there now. I do not believe that this has actually been passed as of yet. Certainly wasn't as of yesterday, but would provide relief to rural hospitals and help address the COVID-19 crisis by, really kind of bolstering financially to the tune of $1,000 per patient day for 3 months to help stabilize the loss of revenue in a lot of these rural facilities, and to increase the Medicare reimbursement rate by some 20% for patients in rural hospitals using the swing bed program. I think I may have read something earlier this morning in going through some of this legislation that recently passed, and I think I may have seen something with regards to a 15% increase to the PPS, but again, don't quote me there. I'm not entirely sure. That's just something that I do not believe has been finalized and passed at this point. The last thing you see here is just some resources that I used in order to pull the information that's housed within this program together. The CDC, CMS, of course, the American Medical Association with regards to the new code they created for the coronavirus testing. And then, of course, Center for Connected Health Policy, which provides some great information as it relates to telehealth coverage, specific, and it's timely as well. So again, my name is John Burns. Again, VP of Audit and Compliance with Arch Pro Coding. We are here to support rural America in every way that we can, not just during the time of this national pandemic, but we're here for you yesterday, today, and tomorrow. So please stay calm, stay safe. Let's all stay informed, and let's just keep educating ourselves. If there is anything that we can do for you, we look forward to having that opportunity. You can see that my email address is here as well. And for additional training, education, certification, audit assistance needs, whatever it is that you may need, we hope to have the opportunity and the privilege to assist you and help walk you down that road. So again, thanks for your time here today. Have a great day. And sorry about that little technological snafu halfway through there. I can't control the internet here at my home. So have a great day, and thanks again for joining us.